Hi, welcome to What's Happening at Tri-City Medical Center. I'm your host, John Bonosoro, for this series made in collaboration with KOCT, North County's channel, and Tri-City Medical Center. Our goal is to keep you informed about health issues, events, and services at your local medical center, and to provide you with information for a healthy lifestyle. With us today is Dr. David Cohen, a cardiac electrophysiologist at Tri-City Medical Center, specializing in treating heart rhythm disorders, also known as arrhythmias. He joined Cardiac Arrhythmia Associates in 2015, directly from George Washington University School of Medicine. He practices at Tri-City Medical Center in Oceanside. Welcome to the show, Dr. Cohen.
Thank you for having me.
I'd like to start with what exactly is the field of cardiac electrophysiology?
So cardiac electrophysiology is a subspecialty of general cardiology. So all electrophysiologists are trained in general cardiology and fellowship, and then do subspecialty training for about 2 years to learn in non-invasive and invasive modalities to treat the whole gamut of arrhythmias. Electrophysiologists in layman's term would be more like the electrician of the heart, whereas interventional cardiologists would call themselves the plumbers. So we deal with electrical anomalies in the heart and improve patients' quality of life, and in some instances even save lives.
So you guys can be identified by your tool belts?
Pretty much, yeah.
Okay. So what's the nature of the work?
So we see patients that are referred to us from typically general cardiologists. So they've come down the pipeline of their primary care physician or an inpatient hospitalist to a general cardiologist, and then they've deemed either by their own diagnoses an arrhythmia, and then they'll come and see the subspecialist, in other words, the electrophysiologist. And at that point, we can either treat them with medications or more invasive modalities such as device therapy and minimally invasive ablation therapy for arrhythmias.
Later in the show, we're going to get into that and in some level of detail. How frequently are people referred? Are we at the point where you almost always end up with a specialist like yourself?
Not necessarily. General cardiologists do have the training in their own tool belt to be able to treat patients medically, at least until they have symptoms or signs of arrhythmia that needs to have more aggressive therapy. However, these days there's more awareness of the field of electrophysiology. Our technologies have gotten better and safer, and I think it's more reasonable for patients on the onset of arrhythmia symptoms or the diagnosis to seek the help of a specialist sooner than later, so they can get the full benefit of the new therapies that are available.
Is the decision solely within the purview of the doctor, or would a patient have some indication as to which direction they should head?
I think that it's not unreasonable for a patient to self-refer themselves to an electrophysiologist, especially in a place like San Diego, where there are plenty of options to seek out a doctor of my specialty. I think it's more difficult if you're in an area that is understaffed or it doesn't have the availability to a specialist. But typically it's up to the general doctor to make that decision whether to seek the subspecialist. Just like if you would see your primary care physician for what you thought was like a thyroid issue, and if they felt like it truly was a thyroid issue, then they would refer you to an endocrinologist. Kind of similar to in our field too.
I understand that arrhythmias fall into categories.
Yes, so the most common types of arrhythmias are either Bradycardia arrhythmias, Brady being slow, cardia being heart, so slow heartbeats, and then tachycardia arrhythmias or tachyarrhythmias, tachy being fast heartbeats. And then regarding the tachyarrhythmias, you can select them into two different groups. So arrhythmias in the upper chambers of the heart, which are the atria, and the atria are the reservoir chambers where blood flows from the systemic and pulmonary circulation, so the veins in the legs and elsewhere in the body or the lungs, and then they settle in the atria before they flow into the ventricles, which are the pumping chambers. So atrial arrhythmias are typically the ones that aren't malignant or life-threatening, but they can increase the risk of issues such as stroke or passing out or a poor lifestyle, versus the arrhythmias down in the lower chambers, which are the ventricular arrhythmias. Those are your more dangerous arrhythmias. Those are the ones that can cause sudden death, and those are the ones that are more common in patients who have other structural heart disease problems, such as heart failure or coronary disease or disease due to heart blockages.
You know, the use of the word sudden death gives me a, you get the little flutter there.
I could see that, yeah.
Yeah. Are the symptoms different for each one of those categories?
Yes, the symptoms can overlap. Typically, if you bradycardia symptoms involve not having enough blood flow to the body and the brain. So typical symptoms of Brady or slow heartbeats are fatigue, difficulty breathing, feeling dizzy, feeling like you're going to pass out. These are all symptoms of Brady arrhythmias or a slow heartbeat. Fast heartbeats can overlap with slow heartbeats too, because if you think about it, if the heart is beating fast enough, you're not getting enough cardiac output or forward blood flow. So you can have this very similar symptoms to slow heartbeats, but typically patients can also feel chest pain if their heart's going too fast. They can feel anxious, and sometimes patients feel nothing at all. They have very nebulous symptoms, and those patients can be difficult to treat because it's difficult to even diagnose them until they present with other symptoms of the arrhythmia that more the result of the arrhythmia itself, whether it be a stroke or heart failure, or when we're specifically talking about atrial fibrillation.
In general, is the nature of this disease one where if you already have pronounced symptoms, it's too late or later than you'd like?
Not necessarily. Most of what we deal with as electrophysiologists, fortunately, is very treatable and reversible. So there are a subset of arrhythmias that are even curable, and we can get into that more. But typically, there isn't a time where we won't be able to offer a patient anything. And usually the symptoms of arrhythmia, the onset is early enough where we can offer something in terms of therapy.
We've got about a minute left in this segment. Can we address causes briefly?
Sure. So causes of arrhythmia are kind of subset into two etiologies or causes. One would be genetic, so something you're born with. Those are usually the arrhythmias that are curable, and we can go into that. The other arrhythmias are due to lifestyle choices or other coexisting diseases. So high blood pressure, diabetes, obstructive sleep apnea, obesity, these can increase your predisposition to arrhythmias in the upper chambers of the heart, the atria. The more dangerous arrhythmias, they can also be due to a genetic predisposition or what's called idiopathic, that we don't know what caused them. So in a normal, healthy patient, they could have a dangerous arrhythmia. But more commonly, the dangerous arrhythmias are due to heart failure and having a prior heart attack that sets the patient up for a dangerous arrhythmia. Other reversible causes of arrhythmia are alcohol, drug use, and stimulant use.
That's a lot of information. We're going to step aside for a minute. If you want further information on electrophysiology at Tri-City Medical Center, please visit tricitymed.org.
Tri-City Medical Center, a leader in advanced healthcare close to home.
When I first came to San Diego and needed a doctor, I found Dr. Ferber.
That was 30 years ago, and since that day, Dr. Ferber has cared for Kathy, her husband, and their 2 children.
Our family has followed Dr. Ferber just so that we could keep him as our doctor. He's so compassionate and up on the latest health issues and advanced technologies.
Over time, they've dealt with some stressful medical concerns.
I don't know how we'd have gotten through our healthcare issues if it weren't for Dr. Ferber and Tri-City Medical Center.
It is my goal to empower patients and promote healthy living. It is an honor to be entrusted with their care. It's all about relationships. We are partners in their health.
Dr. Ferber has always been so accessible. You always feel like you're his only patient. He just really cares.
What I love most about my practice is that we become family.
Tri-City Medical Center, advanced healthcare for you.
Hi, welcome to What's Happening at Tri-City Medical Center. With us today is Dr. David Cohen, a cardiac electrophysiologist at Tri-City Medical Center, specializes in treating heart rhythm disorders, also known as arrhythmias. Welcome, Dr. Cohen.
Thank you.
Let's start with the question of what characterizes a normal heartbeat.
So that's a good question. It's always good to know what normal is before considering abnormal. Normal heartbeats are a one-to-one activity in the upper and lower chambers of the heart. So the heart has an intrinsic pacemaker called the sinoatrial node. It's in the upper chamber of the atria, and that will be triggered regularly. The rate of that triggering can go up under stress and exercise, and it goes down regularly when you're at rest. When that trigger sends an impulse from the upper chamber to the lower chamber, it hits a central circuit called the AV node, or atrial ventricular node, separating the atria and the ventricle. And once that signal is delayed there, it allows blood to flow into the ventricles, and then the dispersion of electricity comes out and squeezes the blood out. So typically a heartbeat will be one-to-one from the sinoatrial node to the AV node to the ventricle. So you get normal sequential contraction of the heart.
We talked about symptoms earlier, and I do want to just get back to one thing. A normal heartbeat isn't noticeable to us.
Yes.
Unless we're under great stress and it's fast. Are all of these irregularities that we're going to talk about noticeable?
Not all of them. So one specific arrhythmia that can be unnoticeable is atrial fibrillation, and we can go into the significance of that, because atrial fibrillation is one of the arrhythmias that increase the risk of stroke. And if it's not diagnosed appropriately or and with good time, it can lead to a clot and stroke. So, but I would say the majority of arrhythmias are, people will feel them. So unless they're very brief skipped beats, which we all have, but usually sustained arrhythmias are diagnosed by patient's symptoms.
Okay. And what about treatment? What are the treatment categories?
So there's three categories of treatment for arrhythmias. There's medications or medical therapy. That's typically first line. Medications that will either keep the rhythm in control, medications that will keep the heart rate or the rapidity of the heart under check if the arrhythmia is more chronic or long-term, such as chronic atrial fibrillation, and also the need in some arrhythmias to be anticoagulated or have a blood thinner. So those are the three classes of drugs. Some arrhythmias are amenable to immediate therapies, invasive therapy. Bradyarrhythmias, as we talked about, the slow heartbeats, there's no medications to treat a slow heartbeat, unless, of course, the patient is on a medication that itself is causing the slow heartbeat, and that can be stopped and it resolves. But typically, if there's an irreversible cause for slow heartbeats, then a pacemaker is necessary. And we can go more into detail what that entails. And then in terms of curative procedures for fast heartbeats, there is a procedure called catheter ablation. And catheter ablation is a minimally invasive procedure where we advance catheters that have mapping electrodes, or they have electrodes tips. It's almost like doing an EKG inside of your heart. And we advance these catheters under X-ray and three-dimensional electrical guidance via large IVs in the upper veins in the leg.
Is there always a progression? For example, is there a possibility where the medical therapy is all that's needed?
Yes.
Forever?
Yeah, definitely. Yeah, there is definitely a subset of arrhythmias that can be treated very well with low-dose medical therapy that patients will tolerate, and particularly in patients who are more advanced in age, it's probably more reasonable to consider long-term medical therapy than anything invasive, and that's up to the discretion of the patient and their physician to make that decision. Some medications are necessary lifetime too, such as anticoagulation, depending on your risk of stroke. However, some arrhythmias, especially those that occur in the young, it'd be unreasonable to suggest that they should be on medications for the rest of their life when they can be cured with a catheter ablation procedure, which is something that can be done in the hospital, and they would go home the same day and never experience the arrhythmia again.
Now I'm going to ask a question that sort of the answer is obvious, but on these shows in general, we like to stress being in touch with your body and knowing it, because obviously treatment becomes, you have more options the earlier it's detected. What percentage of people do you see who are actually waiting too long? Is that a chronic problem in your specialty or relatively minor?
I think it's relatively minor because most people are tuned in that they come to their primary care physician with these symptoms. Their doctors are well trained to make the correct diagnosis, refer them to the appropriate specialist. I think it's more of an issue I've seen in patients that are underserved, and they'll come to you in the later stages. But it's still fortunate that the tools we have can still provide these patients with a good outcome.
All right, well, let's talk about device therapy then. There's two big categories.
Sure. So device therapy involves pacemakers and defibrillators. And the difference between a pacemaker and defibrillator is that a pacemaker treats the slow heartbeats. So the integral aspect of both these devices is the same. It involves a small generator that's implanted underneath the skin on the chest, and then leads that are fed within the vein under the clavicle into the upper and lower chamber of the heart. A pacemaker treats slow heartbeats. So if the heartbeat is too slow, the pacemaker will detect that and send an impulse to the upper and lower chamber of the heart and synchronize the heart back at a normal heart rate. A defibrillator acts just like a pacemaker in the sense that it has pacing function, like I just described, but it's also used to treat very dangerous fast arrhythmias, those malignant arrhythmias in the bottom of the heart, ventricular arrhythmias such as ventricular tachycardia and fibrillation. So the lead in the bottom of the heart will detect those fast arrhythmias, and it will either try to rapidly pace into the circuit, which is a painless a way to break it, or it will send a jolt, which is not pleasant, but it's better than the alternative, which is death.
That's definitely preferable.
Yeah. And the pacing is, patients don't feel it. It's just like having your normal heartbeat. But defibrillation with the shock you will feel. The procedure itself is outpatient in the sense that patients will go home the same day. Very minimal downtime. They are back to their normal activity. It's just a matter of not lifting up the arm where the site was implanted so the leads don't get pulled back. But in terms of returning to your normal quality of life, it's within days, and usually this is an improvement in the quality of their life, especially if they were suffering with very slow heartbeats and the associated symptoms, or they're at risk for sudden death, and now they have that very important insurance policy.
Is this always a lifetime decision for either a pacemaker or defibrillator?
Yeah, they're both called permanent. So these are devices that stay in. Very rarely they can be taken out, but preferably that should be maintained there for the life of the patient.
Well, we will move on to catheter ablation, but not right now because we're out of time for a break. If you want further information on electrophysiology at Tri-City Medical Center, please visit tricitymed.org.
Did you know most men take better care of their cars than they do themselves? Nearly 26% of men 18 to 44 years old in the United States do not have a regular source of health care. Make an appointment today to ensure you stay healthy tomorrow. This message is brought to you by Tri-City Medical Center, advanced health care for you.
Hi, welcome to What's Happening at Tri-City Medical Center. With us is Dr. David Cohen, a cardiac electrophysiologist at Tri-City Medical Center, specializing in treating heart rhythm disorders, also known as arrhythmias. Welcome, Dr. Cohen. Let's start by answering the question, what is catheter ablation?
So catheter ablation is probably one of the most interesting aspects of my work. It involves mapping out the arrhythmias that a patient might have. the first part of a catheter ablation is coming to the diagnosis typically, and by doing that is we advance electrode catheters through the veins in the leg up into the inner chambers of the heart, and we can diagnose an ongoing arrhythmia, or we can actually stimulate the arrhythmia and determine exactly, pinpoint where it is. And then by applying heat energy to the focal area of the arrhythmia, we can terminate it or cure it if it's a specific arrhythmia called SVT, or supraventricular tachycardia. Other arrhythmias involve more extensive ablation, such as atrial fibrillation, and that involves going into the trigger sites for it, which are the pulmonary veins, and blocking those triggers. But the general idea of catheter ablation is a minimally invasive technology to cure or control arrhythmias. And patients typically go home the same day. There are no incisions, and they return to their normal quality of life within days.
So it's a combination diagnostic and treatment tool.
Exactly, yeah. If the patient comes in and the diagnosis is uncertain, we can typically come to a diagnosis that day at the same time that we're going to cure it.
Why is there a special focus on detecting and treating atrial fibrillation?
So atrial fibrillation is the most common arrhythmia, and it's becoming more and more common as the population ages, and as the typical risk factors such as hypertension, obstructive sleep apnea, obesity are more prevalent. It's important to diagnose and treat it appropriately because atrial fibrillation can increase the risk of stroke. During atrial fibrillation, the upper chambers of the heart, they quiver, and a clot can form, and if you're not appropriately anticoagulated, or your blood isn't thinned, and you're at one of these high-risk subgroups, then a clot can form and it can cause a stroke. Fortunately, our modalities to diagnose atrial fibrillation have improved significantly, whether it be with long-term rhythm monitors that are external to the chest, or implantable loop recorders, which are small subcutaneous monitors underneath the chest, under the skin. And then treatment for atrial fibrillation has also gotten much better, safer, and faster. So at Tri-City, we are the only hospital in the northern San Diego region that has the new cryoballoon ablation technology, which uses a balloon-based freezing technology to isolate those triggers, those pulmonary veins, that triggers that lead to atrial fibrillation.
What are some of the other technologies used at Tri-City Medical Center in your field?
Besides the new cryoballoon technology, which it has been very promising and effective for atrial fibrillation patients, we have a implantable loop recorder, which is like a 24/7 continuous rhythm monitor that can be placed underneath the skin. On the same day a patient comes in, we will, it's almost like a microchip for a pet, and they go home with a modem, and that modem is connected directly to their physician, and that device is continuously picking up their rhythm. And so if they have any rhythm abnormalities, their doctor will be aware of it within hours.
So is that a diagnostic tool for things that happen irregularly?
That's a diagnostic tool that can be used for patients who have known atrial fibrillation to determine whether their burden is enough that they would require a blood thinner, or to determine whether therapies we're utilizing are working, and also patients who have been diagnosed with a stroke and they're unsure of the cause. We can use that to ensure that they don't have underlying atrial fibrillation as the cause of their stroke, or for patients who pass out to ensure that there's no arrhythmia as a cause for passing out. Another technology that's very new and exciting is a leadless pacemaker. So a pacemaker that does not have any leads. There's no external generator under the skin, and there are no leads that go into the heart. It's this tiny device about the size of a nickel that we can implant directly into the heart, again from the veins in the leg, and it serves to treat patients who are chronically in atrial fibrillation and just need the lower chamber of the heart to be paced, and it's a way for them to be treated without having any type of surgical procedure or generator. So very promising from that perspective.
You know, you've done a great job of telling us what you do and why. People want to know their doctors too.
Sure.
So if I could ask, what do you find the most rewarding aspect of this specialty?
So I think it's very rare to be in a specialty where a patient will come to you with significant morbidity, that they are struggling with their quality of life, and you can bring them in for a procedure that they will leave the same day and be cured. and they'll come to your office 2 weeks later and say, my life is totally changed. It's rare in the medical field to say that we have cures, and my specialty provides us with the tools for that. And as I was stressing before, there are so many modalities and there's so many new technologies that patients who don't need to suffer for long anymore. If they come even in advanced stages of disease, we can always help them.
So what advice do you have for people who are maybe listening and watching who have arrhythmia?
So arrhythmias, again, are treatable. It's a matter of being educated. It's a matter of making good lifestyle choices beyond just listening to what your doctor tells you or what they do to you, whether it be with medications or a procedure. It's about what you do with your life. So typical heart healthy advice: eat right, exercise, avoid stimulants, avoid alcohol, and understand that treating an arrhythmia is a partnership. It's a partnership with your physician, whether that be your primary care doctor, your cardiologist, or your electrophysiologist, to have that partnership.
On the hierarchy of lifestyle choices, what are some of the other issues that play a role? Does stress play a role in this, for example?
Stress can definitely trigger an arrhythmia, but you have to have the underlying substrate for it. So you have to have either, for atrial fibrillation, the triggers that you were born with, or the underlying heart disease that will, from high blood pressure, start to sleep apnea. And stress in those situations, yes, can trigger the arrhythmia. So again, it's important to try to stay away from those triggers. Again, some arrhythmias are more on a management type of strategy rather than a cure. Atrial fibrillation is one of those arrhythmias that we can't say definitively that we have a cure for it, but we are able to manage it extremely well.
Well, we certainly don't want people to start self-diagnosis, but we do want to give people some guidelines. So just a couple of general questions. Is there a gender difference?
Arrhythmia is almost 50-50 in terms of gender prevalence. Atrial fibrillation probably affects a slightly increased predominance with men, just because of the associated risk factors are more common in men: high blood pressure, sleep apnea. But other arrhythmia, especially bradycardia, is just as we get older, the intrinsic conduction of the heart starts to deteriorate, and so kind of 50-50 between patients. And then genetic causes for arrhythmia, or those supraventricular tachycardias that are curable, are pretty much also equally distributed amongst the genders.
And finally, and we just have a few seconds, is there like a magic age where it really becomes noticeable?
It all depends on the arrhythmia. I think the ones that, again, that are curable, the SVTs that are one area, that can be presented at any age. Atrial fibrillation commonly is more common as we get older, but we do see it increasingly in younger patients in their 30s and 40s because our diagnostic tools are better. And then those slow heart rhythms are typically only an issue in the elderly.
Dr. Cohen, thanks for great information. I know we've done some good today.
Thank you.
And thank you for watching. If you want further information on electrophysiology at Tri-City Medical Center, please visit tricitymed.org. Thanks for joining us on another episode of What's Happening at Tri-City Medical Center. To watch this or previous episodes, visit our video on demand page at KOCT.org. We'll see you next time.